So good afternoon. My name is Thiemo van Nijnatten, and today I'm together with my dear colleague Maxine Jochelson from Memorial Sloan Kettering Cancer Center. I'm happy to introduce you our new paper, which was recently accepted by EGR, considering barriers to implementation of contrast-enhanced mammography.
About the barriers to implementation of contrast-enhanced mammography in clinical practice. And this is going to be in an article published in the AJR by an expert panel, which includes Thiemo, Mark Vokes, Andrea Cozy, Bhavika Patel, Rita Zulli, and myself. Contrast-enhanced mammography was FDA approved in the diagnostic setting in 2011. Multiple studies have demonstrated its ability to improve the diagnostic performance when compared to digital mammography and ultrasound, and that it is not inferior to the performance of breast MRI. There has been broad implementation of contrast mammography, but it has progressed slower than it should. This AJR expert panel review discusses the barriers hindering contrast mammo implementation. Among the barriers to implementation are the risks related to iodinated contrast agents, increased radiation exposure, and workflow adjustments that must be made when performing contrast mammography. Risks related to iodinated contrast agents include contrast allergy, and people are particularly nervous about that, even though the incidence is quite low. In a recently published meta-analysis, Zanardo et al. Demonstrated that out of 14,000 contrast mammo cases, there were fewer than 1% adverse reactions, and nearly none of them were severe. Increased radiation exposure is another concern. However, the radiation dose remains within the MQSA guidelines and the European guidelines. Another detriment is the workflow adjustments that need to be made when performing contrast mammography. Contrast mammo requires an IV line placement, administration of the contrast agent, and a staff to monitor potential allergies.
Yes, thank you, Maxine. The other three barriers to the implementation of CEM, according to our paper, are the indications for which contrast-enhanced mammography is not the preferred test or requires at least further data, incomplete availability of contrast-enhanced guided biopsy systems, and the reimbursement challenges we all have to face with contrast-enhanced mammography. So when we look at the indications when breast MR is still preferred, it is, for the moment, at least for high-risk screening, evaluation of breast implants, posterior lesions near chest wall and lymph nodes. Obviously, for most of them, it's also because there is still no current evidence yet on this field in contrast-enhanced mammography, but potentially future will change it. When we look at the contrast-enhanced guided biopsy systems, they have recently been introduced by a first paper of Rodrigo Alcantara from Barcelona, demonstrating that indeed it is feasible and possible to use contrast-enhanced guided biopsy systems, and potentially this may reduce the need for further MR-guided biopsy systems. Regard to the reimbursement challenges, at the moment there is no CPT code existing for contrast-enhanced mammography. Contrast-enhanced mammography is only FDA approved in the diagnostic setting. However, because there are ongoing CEM trials currently in screening setting as well, it is expected that this will lead to the FDA approval in near future.